Good day. Today we're going to be talking about Chapter 4, Pain. Pain itself is an unpleasant sensation or a feeling of discomfort resulting from stimulation of pain receptors in the body when tissue damage occurs or is about to occur. It's the body's defense mechanism and warning of a problem, particularly when it's acute. It can have several different characteristics, making it hard to define. It is a subjective feeling, impossible to accurately measure. Pain involves complex mechanisms, much of which is not totally understood. Subjective scales have been developed to compare pain levels over time. Pain can occur for a variety of reasons, including infection, ischemia, tissue necrosis, stressing of the tissue, chemicals, or burns. In skeletal muscle, pain can result from ischemia or hemorrhage. In organs such as the liver, kidney, or brain, pain is triggered by pain receptors in the covering capsule, and pain is felt whenever that capsule is stretched by inflammation. Stretching of tendons, ligaments, and joint capsules also elicit pain. These effects may occur secondary to inflammation or muscle spasm to guard a joint or a painful body part. In the stomach and the intestines, pain may result from inflammation of the mucosa, ischemia, distension, or muscle spasms. Somatic pain may arise from the skin cutaneously or from the deeper structures such as bone or muscle conducted by sensory nerves. Visceral pain originates in the organs and travels by sympathetic fibers. Depending on the cause of pain, the pain may be sudden and short-termed, marked primarily by a reflex withdrawal. For example, if you were to touch a hot object, the hand would be involuntarily jerked away from the source of the injury. Or pain may be relatively continuous, as when infection or swelling is present. Nociceptors or pain receptors are free sensory nerve endings present in the body in most tissues. These nerves can be stimulated by either thermal, chemical, or mechanical physical means. Thermal refers to extremes of temperature. Chemical can include things like acids or compounds produced in the body such as bradykinin, histamine, or prostaglandin. Mechanical or physical means could refer to pressure. The pain threshold is the level of stimulation required to activate the nerve ending sufficiently for the individual to perceive pain, the associated nerve fiber that would then transmit the pain signal from the spinal cord and the brain. The pain threshold is relatively constant over time among individuals. It does not vary. The ability to withstand pain or the perception of its intensity is referred to as pain tolerance. Pain tolerance varies considerably with past pain experience and the overall state of health. A nociceptor is a sensory neuron that responds to damaging or potentially damaging stimuli by sending a possible threat signal to the spinal cord and the brain. The brain creates the sensation of pain to direct attention to the body part so the threat can be mitigated. This process is called nociception. The receptors responsible can be found on the skin, joints, viscera, and muscles. The receptors are activated by temperature extremes, chemical substances, and pressure. Afferent sensory fibers conduct pain impulses from the body area to the central nervous system. Myelinated A delta fibers can transmit impulses rapidly. Acute pain, that sudden, sharp, localized pain related to thermal and physical stimuli, primarily from the skin and the mucous membranes, is transmitted by those A delta fibers. C fibers would receive thermal, physical, and chemical stimuli from the muscles, tendons, the myocardium, and the digestive tract, as well as the skin. The unmyelinated C fibers transmit impulses slowly and are responsible for chronic pain. Chronic pain is often experienced as a diffuse, dull burning or aching sensation transmitted by the C fibers. So remember, myelinated A delta fibers transmit impulses very rapidly. They're responsible for the acute pain, and the unmyelinated C fibers transmit impulses slower, and they're responsible for that chronic pain. Each spinal nerve conducts impulses from a specific area of the skin called a dermatome. The somatosensory cortex is mapped to correspond to areas of the body so the brain can interpret the source of pain. Dermatomes can be used to test for areas of sensory loss or pain sensation and determine the site of damage after a spinal cord injury. At the spinal cord synapse, a reflex response to sudden pain results in motor or efferent impulses back to the muscles that initiate an involuntary muscle contraction to move the body away from the source of the pain. Connecting neurons transmit the sensory impulse across the spinal cord to ascending tracts to the brain. There are two types of tracts in the spinal thalamic bundle. The fast impulses for acute sharp pain travel in the neospinal thalamic tract. Slower impulses for chronic or dull pain use the paleospinal thalamic tract. This double pathway explains the two stages of pain one experiences with an injury to the skin. The initial sharp, severe pain followed by a dull but persistent throbbing or aching pain. The spinal thalamic tract connects with the reticular formation in the brain stem, hypothalamus, thalamus, and other structures as they ascend to the somatic sensory area in the cerebral cortex of the parietal lobe of the brain. This is where the location and characteristic of pain are received. The somatic sensory area located in the cerebral cortex refers to the neural pathways that carry information related to touch, pressure, pain, and temperature from the skin, muscles, tendons, and joints to the brain. These tracts connect with the reticular formation in the brain stem, the hypothalamus, the thalamus, and other structures as they ascend to the somatic sensory area in the cerebral cortex of the parietal lobe of the brain. It is here that the location and characteristics of pain are received. The many branching connections from the ascending tracts provide information to other parts of the brain, forming the basis for an integrated response to pain. The arousal state of the reticular activating system in the reticular formation in the pons and the medulla influences the brain's awareness of the incoming pain stimuli. A variety of factors are released upon tissue damage which leads to activation of the nociceptors. When an injury occurs to induce pain, afferent nociceptors from the periphery transmit noxious signals to the spinal cord. These are signals from mechanical, chemical, thermal, or mechanical nociceptors. Afferent nociceptors transmit the noxious signals to the neurons located in the spinal cord. These projection neurons will relay the information to the somatosensory cortex, causing the release of hormones and chemicals that permits the localization of pain and the reflexes that are elicited by pain. The release of hormones and chemicals will trigger a secondary response that can trigger analgesic properties to limit pain sensation. The arousal state of the reticular activating system in the reticular formation in the pons and the medulla will influence the brain's awareness of this incoming painful stimuli. The gate control theory has been modified as the complexity of pain has been better understood, but the simple model serves as a useful tool and visual explanation of pain pathways that can be related to many concepts of pain and pain control. The gate control theory says neurological gateways decide which pain signals pass through and which don't. According to this theory, gates are built into the normal pain pathway in the body that can modify the entry of pain stimuli into the spinal cord and the brain. The gates can also be closed to reduce or modify the passage of pain impulses. Gate closure can occur in response to other sensory stimuli along competing nerve pathways that may diminish pain sensation by modulating or inhibiting the impulse from higher centers in the brain. An example of this is application of ice to a painful site to reduce pain, and this occurs because one is more aware of the cold than they are the pain. Transcutaneous electrical nerve stimulation is a therapeutic intervention that increases sensory stimulation at a site to block painful transmission. The brain can inhibit or modify any incoming pain stimuli by producing efferent or outgoing transmission through the reticular formation. Many factors can activate this built-in control system, including prior conditioning, the emotional state of the affected person, or distraction by other events. If the gate is open, pain signals can pass through and will be sent to the brain to perceive pain. If it's closed, it can block that stimulus though. So if the gate is closed, pain signals would be restricted from traveling up to the brain and the sensation of pain would not be perceived. Again, the gate theory is that the body, the neurological part of the body, can decide which gates will remain open or closed. Serotonin is another chemical released in the spinal cord that acts on other neurons in the spinal cord to increase the relief of enkephalins. Clients with clinical depression often report chronic pain because of a reduction in serotonin levels in the brain. Natural opioid receptors are found in many areas of the brain, as are secretions of endorphins, which can block pain impulses at that level. So blocking pain impulses to the brain is achieved by release of a number of these opiate-like chemicals secreted by the inner neurons within the central nervous system. They act as analgesic or pain-blocking relieving medications and therefore are called endorphins or endogenous morphine. Endorphins include enkephalins, dynorphins, and beta-lipotropins. They block the release of a neurotransmitter substance P at the synapse, and this process prevents transmission of the pain stimulus into that spinal cord. All right, next we're going to look at some characteristics of pain. Pain is a real sensation, but it can also be a subjective symptom perceived by each client. Details that can be helpful in diagnosing the severity and the cause of the pain include the following: the location of the pain, descriptions of the pain, and let the patient describe this in their own words. But we're looking for things such as aching, burning, sharp, throbbing, widespread, cramping, so on and so forth. The timing of the pain or its association with an activity. So when is it worse? Does anything aggravate it or make it worse? So we would be looking at activities such as food intake or movement, or when pressure is applied at the site. Physical evidence of pain, when the client may demonstrate a stress response with physical signs such as pallor, sweating, high blood pressure, or tachycardia. Other signs and symptoms you might see are nausea, vomiting, or fainting and dizziness, which can occur with acute pain. Anxiety and fear, which are frequently evident in people with chest pain, but can be present in other situations as well. Clenched fists, rigid faces, restless or constant motion, lack of moving, protecting or guarding the affected area, restlessness or constant motion, and again, guarding any area to prevent stimulation of that area. So all these things would be signs and symptoms. Infants would respond physiologically to pain first, so what we'll see in them is tachycardia, increases in the blood pressure, as well as characteristic facial expressions. Infants with their eyes tightly closed, eyebrows low and drawn together, and mouths open and square are likely in pain. There's a great variation in the child's developmental stage and coping mechanisms. A range of behavior that may not accurately reflect the severity of pain should be expected. Children may find it difficult to describe their pain verbally. However, children can use drawings of happy or sad faces, mechanical scales, or multicolored symbols to better describe how they feel. Withdrawal and lack of communication are often the result of pain in older children and teens. Sometimes the source of the pain can be localized to a specific area. However, sometimes the pain is perceived at a site distanced from the source. This is called referred pain. Generalized and referred pains are characteristic of visceral damage in the abdominal organs. In some conditions, such as acute appendicitis, the characteristics of the pain may change as the pathological conditions occur. For example, pain in the left neck and arm is characteristic of a heart attack or ischemia in the heart. Pain in the shoulder may be attributed to stretching of the diaphragm. Multiple sensory fibers from different sources connecting at a single level of the spinal cord make it difficult for the brain to discern the actual origin of the pain. This is in referred pain still. In phantom pain, pain or another sensation such as itching or tingling occurs in some people, usually adults, after an amputation. The phantom pain is perceived by the person as occurring in the lost limb and typically does not respond to usual pain therapy. The pain can resolve within weeks to months. It appears that the brain understands the limb to still be present when processing the incoming stimuli. The phenomenon is not fully understood. Tolerance may be increased by endorphin release or reduced by other factors such as fatigue or stress. It does not depend on the severity of pain. It varies among people and different situations. Pain perception and response are subjective and depend on the person. Factors such as age, culture, family traditions, prior experience with pain, which shape someone's perception and response to pain. Pain can be compared from day to day in the same person. Anxiety, fear, and stress can increase the severity of pain because the central nervous system is at a higher level of awareness. Fatigue, hunger, and the presence of other illnesses or problems can also magnify a person's response to pain. With acute pain, the onset is usually sudden and severe but short-lived. This indicates tissue damage and decreases once the cause is treated. It can be localized or generalized. It usually will initiate a physiological response with increases in blood pressure, heart rate, a cool, pale, moist skin, increased respiratory rate, and increased skeletal muscle tension. Vomiting may also occur. There may be a strong emotional response as indicated by facial or verbal expressions and a high level of anxiety. Chronic or long-term pain can lead to different and negative effects such as loss of employment or interference with personal relationships. Chronic pain is usually more difficult to treat effectively. Prognosis may be less certain. It's difficult to identify an exact location. Because a specific cause may be less apparent to the person experiencing the pain is more difficult to deal with and can be debilitating and harder to treat. It's impossible to sustain a stress response over a long period of time, and therefore the client with chronic pain frequently is fatigued, irritable, and depressed. Sleep disturbances are common. Appetites may be affected, leading to weight gain or weight loss. Chronic pain frequently affects a person's daily activities and may become the primary focus in the life of the client. Periods of acute pain can accompany exacerbations of chronic disease. Long-term pain usually reduces tolerance to any additional injuries or illness. This chart is going to compare chronic and acute pain, and I would take a good look at it. As previously stated, they do like to look at these charts and test you from it, like your fast delta myelinated fibers. Those are going to be for acute pain, whereas the slow unmyelinated C fibers are for chronic pain. The A delta fibers are going to travel in the neospinal thalamic tract, whereas the chronic pain fibers are going to travel in the paleo-spinal thalamic tract. So I would know, what are the expectations? What's the difference between these two? Headache is a common type of pain. There are many categories associated with different causes. Some have specific locations and characteristics. Headaches that are associated with congestion, like in the sinuses or nasal congestion and eye strain, are located in the eye and forehead area. Sinus headaches can be severe. They're usually steady and relieved when the cause is removed. Tension headaches with muscle spasm result from emotional stress and can cause neck muscles to contract, pulling on the scalp. Sometimes when people work for long periods of time in one position, contraction and spasm of neck muscles can occur, causing a dull, constant ache, usually in the occipital area. Tension headaches tend to persist for days or weeks usually. Headaches in the temporal area are often associated with temporal mandibular joint syndrome involving the jaw or inflammation of the joint caused by arthritis or poor body alignment, which causes muscle tension in the neck that involves the jaw, or inflammation of the joint caused by arthritis or poor body alignment. And this can lead to muscle tension in the neck that is then transferred to the jaw. Migraine headaches are related to abnormal changes in the blood flow and metabolism in the brain. Pain is associated with a migraine is usually going to be throbbing and severe and also incapacitating. So usually we have some sort of dilation here of the blood vessels, irritating. Intracranial headaches can result from increased pressure in the skull, any space occupying mass that stretches the cerebral vascular walls, or the meninges that are covering the brain. There are also many precipitating factors, including atmospheric pressure, stress, menstruation, dietary choices, and hunger, that can affect the severity and duration of a headache. Central pain is pain caused by dysfunction or damage to the brain or the spinal cord. A lesion such as an abscess, infarction, hemorrhage, tumor, or damage from a direct injury may cause central pain. It can be localized or involve a large area, be persistent and irritating. Neuropathic pain is caused by trauma or disease involving the peripheral nerves. This type of pain can vary from tingling to a burning or severe shooting pain. Movement can stimulate the pain as well as injured nerves that can become hyperexcitable. Neuralgias are examples of extremely painful conditions that are a result of damage to the peripheral nerves caused by infection or disease. And ischemic pain results from a profound, sudden loss of blood flow to an organ or tissue in a specific area of the body. Decreased blood supply results in hypoxia, leading to tissue damage and release of inflammatory and pain-producing substances. A description of the pain can vary from aching, burning, or prickling to strong shooting pain, especially if it occurs in an extremity. Atherosclerotic disorders cause blocking of arterial flow that can cause ischemic pain, especially in the lower extremities. Cancer is often associated with chronic pain. This pain has been broken down into several categories. Pain caused by the advance of the disease and the resultant damage to the body. Pain associated with the treatment of the disease. Pain that is a result of a coexisting disease unrelated to the cancer. The most common category encountered in cancer-related pain is that caused by the advance of the disease. This type of pain may be characterized as acute with sudden onset, intermittent, or chronic, persisting over a period of time, for a long period. All right, so all these are the pharmacological methods of pain. All right, we want to take away the pain as soon as possible. We can use analgesics. This can be given a variety of ways, orally, through injection, through patches, IV, and we're going to treat according to what sort of pain that they have, whether it's mild, moderate, or severe, whether it's nerve pain, because nerve pain would be treated differently, as we discussed with like fibromyalgia. And if you look at table 4.2 in your book, it describes the different drugs and what you would use for what type of pain based on the drug and what part of the body it's going to affect. Again, we're not focused on treatments for this course, so I'm not going to spend a lot of time on it. Just take a brief look at it so you know when you're out there on the floor what you're given what for. Other methods of managing pain include sedatives, anti-anxieties. We may also, if it's cancer, we may also try to do some kind of thing to reduce the size of the tumor or remove a tumor. There's other things that we can do there also to reduce pain. So most of these are going to be pharmacological. There are other methods we can do. All right, and then here it's talking about severe pain. Again, we're talking about medications here. Now, when the pain can't be controlled with medication, it's considered intractable. So we may do some sort of surgical intervention, a rhizotomy, cordotomy, injections. We also look at trigger points. Trigger points are focal areas of muscle spasm and infection of skeletal muscle. So these might be areas that we can use to relieve pain for conditions like myofascial pain syndrome or fibromyalgia. Injections for these areas could include anesthetics, steroids, or Botox. Surgical implants, the TENS unit, that's going to be more non-invasive, and then bioelectric therapy, which provides temporary pain control, but this can only be used as part of a total pain management program. And then there's also some surgical things we can do, like intrathecal pumps, which deliver drugs like Botox and other things, and then spinal cord stimulation implants. And then, of course, anesthesia. This can be spinal or regional. It can be general anesthesia or neurolepta anesthesia, which the patient can respond to commands, but they're not really aware of the procedure itself, what's happening. And then, again, more of your anesthesias. All right, and that concludes pain.